非常感谢您。
Person for your kind introductions. My topic today is on fibroids and fertility. So we know that fibroids are the most common benign tumors in women of childbearing age, and indeed 30% or more women who are suffering from infertility are found to have fibroids. But of course, some of these fibroids are incidental findings, but among these women who has infertility, about 2 to 3% of them, the cause of the fertility can be attributed solely to the fibroids alone. And women with fibroids are also found to have higher risks of recurrent miscarriages. I think many of us in our clinical practice, we do realize that if a patient has fibroid, especially the submucous fibroid, and the rate of miscarriage is reported to be up to 2 to 3 times higher than women without fibroids. Let's take a look at the classification of fibroids. This is a FIGO classification described by Monrose, and you can see that the fibroids are described based on its position from type 0, which is essentially a submucous 内膜下肌瘤到type 7, which is 浆膜下的肌瘤 subserosa fibroid. And the rest are the fibroids in the various positions in between these two. Donis has this schematic drawing describing the position of fibroid, which I thought was very interesting. So you can see that a type 0 is right underneath the endometrial layer, and the rest are in between, and the type 7 is right above the myometrium. Yeah. So take a look at this fibroid, because the positioning and the locations of the fibroids can sometimes be challenging, even with the help of a hysteroscopy. So you look at this fibroid, I think at the beginning, you will have realized this is actually a type 2 fibroids. But you can see when the intrauterine pressure increases, the fibroids actually was pushed up. So adjusting the intrauterine pressure, or in fact, when you want to determine the positions of a suspected type 1 to type 2 fibroid, one must use very low intrauterine pressure, because if not, you can easily be mistaken, push away the type 1 fibroids into the myometrium and totally miss one that requires surgery. So fibroids cause symptoms, of course. What are the main features that affect the symptoms of a patient? 1, size; 2, the numbers; and the 3 most important is the location. And some of the symptoms that a woman present when they have fibroids includes heavy menstruation, pressure effect, and of course some of them will complain of infertility. So, can fibroids cause infertility? I think if you have an intramural fibroid or a subserous fibroid situated very close to the tubal ostia, then obviously it can cause a mechanical obstruction, and without any suspicion, then this fibroid probably need to be removed because it's causing a mechanical obstruction. But many of them, they are not situated close to the tubal ostia. So how can they affect fertility? Many researchers have suggested, 1, perhaps due to an altered peristalsis of the myometrium. The presence of fibroids can change the contractility of the fibroid and therefore affecting the implantation of the embryo. And another group of researchers felt that the presence of fibroid, especially in the pseudocapsule area, it causes a change in the microenvironment of the endometrium. And these changes in the microenvironment could be due to the presence of immunological factors, endocrine factors, such as IL-10, cryoctadines, and so on, and the HOXA10. And it is believed that these changes in the microenvironment leads to problems with the embryo implantation. Okay, so this is a meta-analysis published in 2009 by Elizabeth and Priest, examining the effect of fibroids on fertility. She included 23 studies, of which one was a randomized control trial, 9 prospective and 13 retrospective studies. So in this meta-analysis, it was found that comparing women with fibroids versus no fibroid, any type of fibroids appeared to reduce the clinical pregnancy rate, the implantation rate, and the live birth rate, and of which a submucous fibroid has the greatest impact, with the greatest reduction in the implantation, clinical pregnancy, live birth rate. But when she examined the presence of an intramural fibroid versus no fibroids, it is realized that it reduces the implantation rate. But if those studies do have the hysteroscopy examination incorporated as well, they found that if the patient successfully got pregnant with an intramural fibroid, there's not much effect on the clinical pregnancy rate or the live birth rate. And this is a paper published in the same year, 2009, by Sankara. But in this paper, the meta-analysis is done on the subset of these fibroids. Only the intramural fibroids were studied versus the outcome of IVF treatment. And the conclusions of this study is that the non-cavity distorting intramural fibroid is still responsible for a reduction in the live birth rate. And a more recent update of the meta-analysis in 2018, again, is looking at the impact of non-cavity distorting intramural fibroids on the efficacy of IVF and embryo transfer. And again, these studies concur with the previous studies that even in the intramural fibroids, non-cavity distorting can also reduce implantation rate, clinical pregnancy rate, as well as live birth rate. So then, if the intramural fibroid reduces the chance of a pregnancy, the size matter? In this paper, it looks at the effect of size and number, and it is concluded that the intramural fibroids, more than 2 centimeters in size, has a significant impact, has a negative impact on the live birth rate, but there's no increase in miscarriage rate if the patient do get pregnant. Then a separate paper, again, demonstrated that intramural fibroid, if they are more than 2 in numbers or size is greater than 3 cm, show a negative impact on the clinical pregnancy rate as well. So if you do know that, if you do believe that intramural fibroids reduces fertility, so what about surgery? Does removing the fibroids improve the fertility outcome? Well, in general, most of the papers have suggested that if the cavity is distorted by submucous fibroid, removal is generally recommended, because it has been shown with fairly conclusive evidence that removal of such fibroids improves the fertility outcome. And the same paper analyzed that. They found that the clinical pregnancy rate increased by 2 times when the fibroid was removed, if it's a submucous in location. Whereas it's quite clear that the fibroid, if it's subserous, I think we're not going to discuss too much, because so far the evidence has shown no improvement in fertility when you remove a subserous fibroid. Unless you consider removal if you think that these fibroids could potentially obstruct oocyte pickup, or it is very close to a tubal ostia. So the most challenging question lies in this group of fibroid, the intramural fibroid, the type 2, the type 3, and those spanning the myometriums from 2 to 5. So does removal of this fibroid improve fertility? It remains controversial. There are equal numbers of papers pointing in either direction. Some say yes, some say no, but there's no conclusive data. The paper by Briggs, again, when they analyzed the subset of intramural fibroids, and they compared patients with surgery versus no surgery, they found that there were no significant change in ongoing pregnancy or live birth rate. And in this single center retrospective studies that was done in 2006 to 2015 in Cleveland, it found that the group of patients who underwent myomectomy versus the other groups of patients who had either leave-it fibroid alone or patients who have no fibroid, they do experience a shorter time to pregnancy, but when the pregnancy occurs, there is not much difference in the cumulative live birth rate. So essentially, the data from these two studies suggested that it doesn't seem to improve the take-home pregnancy rate if you were to perform myomectomy on this intramural fibroid. But while the effect on fertility remains unclear, but we do know for sure if we perform myomectomy on the women who desire fertility, it has potential consequences. One, it leads to post-operative adhesion formation. It can distort the tube and can cause adhesion-related problems. And if during the surgery, it breaches the endometrial cavity, it weakens the myometrium, for sure there is a risk of uterine rupture. So we all know that a post-myomectomy has the highest rate of causing adhesions formation. It can range from 36 to 67%. And you know that after a uterine surgery, especially myomectomy, especially multiple site myomectomy, there's a risk of uterine rupture if the patient do get pregnant. And again, the ASRM, based on all the current data, has no clear benefits for subserous fibroid, which we know. Submucous fibroid, yes, I think there's enough evidence to suggest that removal will improve fertility outcome. And intramural fibroid, as what we mentioned, it appears to affect fertility, but removal of it doesn't seem to show a better outcome. So in summary, non-cavity distorting intramural fibroid pose the greatest clinical challenge. Sufficient evidence points to a reduced fertility, but their surgical removal does not seem to improve pregnancy outcome. So the fertility benefit for this group of patients must be balanced against the risk of post-myomectomy complications such as risk of uterine rupture, associated maternal mortalities of the surgery, and at the same time, I think we need a wide range of armamentarium such as medicine, non-invasive therapy, and surgery to deal with a very common women disease. I think at the end of it is that there's no one size that fits all. No one treatment modality is the best for all patients. And if we have a wide range of medical treatment, surgical treatment, and including non-invasive treatment, the patient, the best surgery, the best treatment modality can be tailored for them to achieve the best outcome. With that, I thank you, and give me a second to promote the events that we are organizing in October this year. It's the APH annual meeting will be held in Singapore from the 25th to the 28th of October. There will be 2 days of main congress covering a wide range of topics. These are the faculties that have agreed to join us from 18 countries. And this is a summary of the program. And we have a few workshops, pre-congress workshop, that includes a robotic workshop, a venous workshop, electrosurgery workshop, laparoscopic animal model, and the hysteroscopic workshop as well. If you have time, please join us for this October meeting. Thank you very much.